Good morning, dear professors and doctors. I'm resident Mustafa Ali, a resident at Department 16, representing Professor Dr. Hani Hamza's unit. Today I'm going to present a case with the title of Is it just a birthmark? Under the supervision of Professor Dr. Sharif Kamil. So, is it just a birthmark? Let us see in future slides. My case is about a 27-year-old female patient, medically free, with a left side port-wise stain since birth. The patient presented to us on 1st of June with gradual progressive bifrontal headache, associated of 2 years duration, associated with vomiting and blurring of vision. The patient reports transient visual obscurations of 6 months duration. The patient was on timolol, non-compliant. There was no history of ocular or other surgeries, no history of ocular surgeries or trauma. There was negative consanguinity, no family history of ocular or other diseases, no history of seizures, and no history of upper or lower limb weaknesses. On examination, the best corrected visual acuity was 6.6 on the right and 6.9 on the left. Fundus examination showed a grade 3 papilledema on the right side and 2 on the left. Intraocular pressure was high, ipsilateral to the birthmark. We requested a bilateral OCT optic nerve head and perimetry, and the patient was asked to apply bronzolamide timolol combination instead of timolol, and the patient was referred to neurology. The OCT showed increased thickness of the nerve area, more on the nerve on the right, denoting the papilledema. The perimetry showed the dense low arched scotoma on the right side. At the neurology department, a lumbar puncture was performed to confirm the diagnosis of increased intracranial tension. The patient was then asked to take acetazolamide with a starting dose of 750, increased to 1,500 a month later. MRI and MRV were requested, but were found to be normal. During subsequent visits, the patient reports improvement of her headache, and the papilledema slowly resolved. But one thing noticeable, that was always noticeable, that the papilledema was always asymmetrical and always more contralateral to her birthmark. During follow-ups, again, an OCT optic nerve head was requested and perimetry. The OCT showed a severe reduction of retinal nerve fiber layer on the right side. The left was within normal. Perimetry again showed a dense low arched scotoma on the right side. The patient was referred to the glaucoma clinic, knowing the nature of her disease. Sturge-Weber, the most common ocular complication of Sturge-Weber is glaucoma, occurring in about 30 to 70% of the cases. In Sturge-Weber, the glaucoma has a bimodal presentation. Early onset occurs in about 60% of the cases, thought to be due to congenital angle anomalies. In the remaining 40%, an adult onset or late onset glaucoma occurs that is thought to be due to elevated episcleral venous pressure. Knowing these facts, the patient was referred to the glaucoma clinic, where her angles were found to be normal. Again, the IOP was found to be elevated ipsilateral to her birthmark. The patient was asked to apply brimonidine in addition to her anti-glaucoma treatment already taken. The fundus showed a pale disc on the right side. That's how the fundus looks like. The patient was referred to the Neuro-Ophthalmology clinic. Sturge-Weber disease, also known as encephalotrigeminal angiomatosis or leptomeningeal angiomatosis, is known to affect the brain by angiomatous lesions, which most commonly occur in the occipital lobe, but can affect other regions of the brain. These angiomatous lesions can directly increase intracranial tension or by impairing cerebral venous outflow. Ultimately, cerebral atrophy and calcification occur. These can present ophthalmologically by various field affections, including homonymous hemianopia or other field affections. This study, published in the Journal of Neuro-Ophthalmology, shows that optic atrophy in Sturge-Weber can occur by post-glaucomatous, post-hydrocephalic, also known as post-papilledemic, or even by direct infiltration of the optic nerve by the angiomatous process, as shown here. Knowing these facts, MRI and MRA were requested, but were again found to be normal. One thing that was quite noticeable in this patient was that the intraocular pressure was always high ipsilateral to the birthmark. That's quite known. But the papilledema and the supposing a post-papilledemic optic atrophy was more on the right side, contralaterally. So is this just an incidence, or is there actually a relation between the intraocular pressure and the intracerebral pressure? I reviewed a number of studies that show how intraocular pressure and intracerebral pressure counteract at lamina cribrosa, forming what's known as a translaminar pressure gradient. In homeostatic conditions, a translaminar pressure gradient of about 2 to 33 millimeters mercury occur with a net positive pressure posteriorly. So it's not only about increased intraocular pressure to cause glaucoma. Now studies show that an increased intracerebral pressure alone can be a risk factor for glaucoma. And an increased intracerebral pressure may sometimes be counteracted by an increased intraocular pressure, not resulting in the atrophy or reducing the effect of the papilledema on the disc. This study shows that the IOP, the intraocular pressure, is one of the causes of asymmetrical papilledema. The study recommends ophthalmologists to always measure IOP in the settings of asymmetrical papilledema. The study also concludes that a marginal rise of intraocular pressure can be used in the future as a way to treat papilledema. This study shows that in some people with IIH, the papilledema was only unmasked after using drugs to lower the intraocular pressure. This study shows that a decreased intracerebral pressure is one of the risk factors now known to be a risk factor for glaucoma, at least in this study, and it correlates the increased incidence of glaucoma with age due to the decreased intracerebral pressure with age. The study also shows that glaucoma risk is higher in some patients with Alzheimer's disease due to the same reason. Finally, I want to talk about the most common ocular complications of Sturge-Weber. I already talked about glaucoma. The second is diffuse choroidal hemangioma, which is known to exclusively occur in patients with Sturge-Weber. It may present with affect vision by causing hypermetropia, because it decreases the axial length of the eye. Secondly, it may cause a serious retinal detachment. It may cause a cystoid macular edema presenting with metamorphopsia. It appears in the fundus examination with a classically, say, tomato ketchup appearance, and we can do B-scan ultrasound to diagnose it. Classically treated with photodynamic therapy, laser photocoagulation, radioactive brachytherapy, and multiple studies now use oral propranolol to treat it. It's efficient in some studies, but not very reliable. The response is not always, it does not always lead to the treatment of secondary serous retinal detachment. We only treat the diffuse choroidal hemangioma if it's symptomatic. Usually it may not be treated. The Sturge-Weber may also present with iris heterochromia, blood in Schlemm's canal, homonymous hemianopia, as I already said. This slide shows how visual acuity and visual field can be affected in both eyes in patients with Sturge-Weber. So my take-home messages: one thing is that all infants born with a port-wine stain should undergo regular ophthalmological examinations to exclude early onset glaucoma. The ophthalmologist should measure IOP, at least in the study that I revealed, in the settings of asymmetrical papilledema. Optic atrophy in Sturge-Weber can be due to various reasons. The relation between IOP and intracerebral pressure, oral propranolol, has been shown to be effective to treat diffuse choroidal hemangioma, although not very reliable. Finally, it's not just a birthmark. Thank you and Happy New Year.